Good afternoon, everyone. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to all the respected dignitaries and faculty who have gathered here today for today's event. The theme for today's program is high risk pregnancy, and we've been conducting this series since the beginning of lockdown. I don't know how many programs they've conducted, but they've always been very popular with both the faculty as well as the audience. We usually have an average attendance of 400 to 500 per event. We're really happy that this series has been taken to heart by all Foxians and they've participated in the form of attendance as well as excellent comments, feedback, and suggestions regarding topics for this series. We have two eminent speakers today, but before we start the scientific proceedings, I would like to start with a mark of gratitude and respect to our dynamic president of AMOGS, Dr. Nandita Palchetkar. Madam is the current president of AMOGS and the immediate past president of FOXY. She has also been the president of the Mumbai Society, IAG, and chairperson of Maharashtra chapter of ISAR in the past. We thank her for her blessings and support throughout this entire series of lockdown webinars which we've been conducting. Next slide, please. I'd also like to express my gratitude to Dr. Arun Nayak sir is the secretary of AMOGS. He's been a past president of the Mumbai OBGYN Society and he is somebody who's always for academics and he's always encouraged, promoted and supported his juniors in all such endeavors. Next slide please. At this point, I'd also like to express my gratitude to the ICOG chairperson, Dr. Mandakini Megh, the secretary, Dr. Parag Biniwale, both of whom have been supportive and granted us ICOG credit points for all our webinars so far, including today's event, which is accredited with one ICOG credit point. So thank you to the office bearers of ICOG. Next slide, please. We have three very eminent chairpersons who have joined us today. The first of these is none other than Dr. Rajendra Singh Pardeshi. Sir is the current Vice President of AMOGS. Last year, he was the Vice President of Foxy with Dr. Nandita Palshetkar ma'am when she was the President of Foxy. Sir has some very distinguished credentials and he is 6 times Best Paper Awardee at AICOG conferences, probably a record which can never be equaled, let alone broken. He has presented over 27 papers and he has a multitude of presentations at international fora as well. He has 7 articles in recognized journals, chapters, and textbooks in articles and Foxy Focus and so on and so forth. We're really delighted to have Dr. Rajendra Singh Pardeshi with us. Thank you so much for joining us today, sir. Next slide, please. We are really grateful that in spite of her busy schedule, Dr. Archana Verma, the Vice President elect of Foxy, is here today. She is a very dynamic and very distinguished lady as far as public awareness and public health is concerned. She's been the past chair for the Public Awareness Committee of Foxy. Now, of course, she's the Vice President elect. She will take over very soon. Also, she has to her credit the past presidentship of the Ghaziabad OBGYN Society, organized several conferences, including the UP ISA, the midterm UPCOG, and several other conferences in the past. Awarded so many different distinguished awards, but I think the most important of these is the UP Governor's Award, which is the appreciation award presented to her a couple of years back, and she also has many other distinguished awards to her credit. Thank you so much, Dr. Archana Verma, ma'am, for being here today and taking time out from your schedule. Next slide, please. We are privileged to have a very young, dynamic, and energetic Foxian with us today. Dr. Rashi Mishra is a consultant in reproductive medicine and director at the Shivani Hospital in Kanpur. She is also director at Kusum IVF in Chindwara. I hope I got the pronunciation right. She's done her MBBS and MS from MGM Medical College, Indore. She has a doctorate in reproductive and sexual medicine with gold medal from the Tamil Nadu MGR University. She has an IVF center in Kanpur, which has been awarded the center with the maximum success rate in North India by the Uttarakhand Chief Minister, Shri Trivendra Singh Rawat. And she has, of course, several presentations and participations at national conferences. We are delighted to have her with us today. And I hand over to the three chairpersons to carry on the proceedings. Owing to a minor technical issue, we are going to switch the order of the two speakers. Dr. Alok Sharma will speak second, and Dr. Anju Soni is going to speak first for her formal introduction. I hand over to the chairpersons and request them to take us through the further proceedings. Dr. Archana Verma, ma'am, would you like to introduce, please?
Yes, it's thank you, Dr. Pratik. I really feel honored to come to EMOX and the way Dr. Pratik gives introduction. So that's why I have to come. So, and today I am my proud privilege to introduce the most dynamic and determined Anju Soniji from Jaipur, and she is currently our chairperson HIV and AIDS committee, and she is a one person who wants to bring changes, and she will be doing a lot for everybody, especially this HIV problem is to be tackled seriously, and only dynamic persons like Anju Soni can do it. And she has got many things to her credentials. She is a past president of Jaipur Society and Jaipur Menopause Society also, and a committee chairperson of IMS, and vice president. She was of the JOGs, and she has taken, I mean, all the post of the good worker, and done very well, and a life member of so many societies, and won many awards, and doing so much of great work. So, Dr. Soni from Sony Hospital, Jaipur. Please take over, and the mic is yours. And let's hear what you say.
Thank you, Dr. Archana, for such a introduction. I am humbled, and I am. It's very kind of you to give such an introduction. Thank you very much, Dr. Archana. You are always a icon for all of us, and I would like to share my screen, and we would love to work under you. Times are coming that we are all going to work together, and I'll need a lot of your guidance. So please keep guiding us in future. You are a master of public awareness. The whole country knows about it. So I need you more than anybody in the Foxy. So your support will be always there, along with the support of
definitely, undoubtedly, definitely. कुछ है नहीं, हमको तुम्हारा साथ चाहिए. We want you to be with us.
Along with Dr. Rajendra Singh, he has also been a pioneer in all this, and he is always guiding me to the truth path. And I am very, very thankful to MOGS, Dr. Nandita, Dr. Arun Nayak, and I am also thankful.
MOGS is a great platform indeed.
Yeah, definitely. And if a person like Pratik is there to carry on the baton of the, this MOGS, I think there is no better person than Pratik who could carry it further. Pratik, you really need lots of applause and claps from all of us. You are doing a great job as far as the education is concerned, academics concerned. Please keep continuing. You are doing a great job, and you are teaching all of us. You are teaching all of us how to go further.
हम तब मानेंगे ना अंजू, बड़ी बड़ी बातें मत बनाना, हमें जयपुर बुलाओ, अच्छी सी बहुत बड़ा सा खूब अच्छा प्रोग्राम रखो और हमारा सब इंतजाम रखो वहाँ पे, तब हम आते हैं.
आप कोरोना को हटाओ, फिर अपन जयपुर में मिलेंगे.
अरे देख, कोरोना हटा पड़ा है, हमने कह दिया हट गया, तुम अब करो.
Thank you. No,
वैक्सीन और लग गई, बस अब सेकंड वैक्सीन के बाद प्लान करो.
You're welcome. Now, I welcome all the organizers, the chairpersons, and also the delegates who are here today. And they are the one who make any academic program what it is. And so I welcome all of you. Now, we are going to discuss about, as obstetrician and gynecologists, we have lots and lots of cases which come to us in our everyday life. And these are the cases where we need to know that how to go about them. So let's discuss some of the cases which come to us almost every day. All of us, we have just been through a pandemic, and which we had never thought of, which we had never heard of. And all of us, you must have might have thought of these lines in your mind, that just as one might predict for the disease that is not yet fully understood, as well as extremely recurrent to treatment, has essentially provided a large scale occasion for metaphorizing illness. And these lines are not told today. These were written by Senteng XS somewhere in 1989 for the HIV pandemic. And again, when we come to talk about it, there are people who have lived in the HIV era and who have also seen this era of COVID-19. They have seen what crisis AIDS went through. But they today, with the advent of modern medicine and modern treatment, we all know that a disease which at one time was a sentence to death has come to stay as a chronic illness, where a simple dose of medicine can control it, and prevention can help us. Again, there have been a lot of similarities between the both viruses. People are talking that they are very similar to each other, but whatever we have seen, that SARS-CoV virus does not have a long term effect, and HIV has been there with us almost after 40 years today with us. So what? The main thing is that we have to talk of prevention, and prevention is the only thing which will prevent us from overcoming this disease. Now, a woman may come to us in her first trimester. She is found to be HIV reactive. Now, it comes to our mind: what treatment should be given to her? What are the risk factors which will prevent the transmission to the child? And if she never turned up in the treatment and presented directly in the labor, what are the steps of management? Similarly, there is another case, a case who is known to be an HIV positive, is presenting to us in 3 months of pregnancy. She was diagnosed 5 years back in her previous pregnancy, where she received nerve prime, and her CD4 count is 570. Now, the question comes to our mind is, what are ART to be given? And does she require ART? And if she requires, what kind of regime to be given? And what could have been given to prevent this pregnancy? Another case comes to us. There's a woman who is diagnosed 7 months back in her last trimester of pregnancy, gives history of providing some medicines, and she took it till delivery, and then she is reporting back to us after 5 months of her breastfeeding baby. So these are the few cases which comes towards almost everything. Coming slides, I hope, will solve your problem of these cases, and you will know how to manage them. Now, when we talk of HIV is basically nothing but a continuum of care. The care which is not only there in antenatal period, in intranatal period, and postnatal period, it is there throughout the pregnancy. And we need to counsel the woman to start ART as soon as possible and continue it throughout the pregnancy, in the postnatal period, and also lifelong. So this is the most important thing when it comes to HIV. Now, when we talk of HIV, the main cause of transmission in a child is through the mother. And whenever there is what are the basic factor which increases the transmission is the high viral load. And that is a factor which decides the transmission, which can occur during the pregnancy, during the labor, and also during the breastfeeding time. Now, little we need to understand when we are talking in depth of the Indian scenario. We all know, though the prevalence of HIV is very low in our country, that is 0.34%, but being the largest number of patients living with HIV, that is 2.1 million, we are still having a huge number of people. And women account to 40% of total infections, and 21,000 children are infected every year. This is a big number. Then nearly 5% of these infections are attributable to the mother-to-child transfer, and more than 70,000 children are living below the age of HIV. So it is very important for us to talk of transmission. As said, that the mother to child transmission occurs because of high viral load. If there is no intervention taken during the pregnancy, the highest transmission occurs during the labor. So our aim is to pre-start the treatment as early as possible so that we can avoid the transmission during pregnancy, during labor, as well as during the breastfeeding. Now, what are the different factors? So when we talk of the factors, there are maternal factors during pregnancy, during labor, and during breastfeeding. Let's come to them one by one. When we talk of maternal factors, as I already said, the high maternal load is the one of the most important factors. Acute infections occurring during the pregnancy, advanced disease in the mother, viral and bacterial parasitic infections associated with it, and also malnutrition and other STIs. Now when we come to the other factor during the labor, that is again acute HIV infection. HIV infection is in the mother in the advanced stages. Again, high maternal viral load, prolonged labor, or premature rupture of membranes associated with acute chorioamnitis. Invasive childbirth procedures have to be avoided. And of course, premature birth is one of the greatest risk factors, along with the multiple birth. Another factor is the breastfeeding. There have been lots of myths about breastfeeding in the HIV from HIV babies. So here we are just wanting to know what are the factors we increase the rate of transmission during the breastfeeding. They are basically acute HIV infection during the breastfeeding, advanced disease, high maternal load, duration of breastfeeding. If it is more, and if it is basically the mixed feeding is the most risky thing, and if a woman has any breast involvement because of abscess or fissures or mastitis, it increases the chances, along with, of course, maternal malnutrition and oral disease in the infant. Now, how do we prevent the disease? We can prevent the disease, transmission by preventing the HIV in the childbearing woman and provide HIV information to all the pregnant women. And antenatal visits should be taken as an opportunity to control this problem. And we have to prevent the unwanted pregnancy in HIV positive women. First, control their infections, and then we tell the patient once her viral loads are less, she should conceive that time. Again, nutrition counseling and institutional delivery is very, very important. Now, when a patient comes to us for the register for the pregnancy, we have to start therapy as soon as possible. It has to continue throughout the pregnancy, and even if a woman presents to us very late, she has to be started immediately and managed accordingly. So, what are the current guidelines? The current guidelines are that all positive pregnant and breastfeeding women to start ART is irrespective of their CD4 count, irrespective of their WHO staging, irrespective of their duration of gestation, and ART should be lifelong. It has to be triple drug, and there are different regimes for HIV-1 as well as HIV-2 or both infections. Now, what ART to start? Very important question. We have been giving TLE. This slide looks slightly busy, but when we try and understand, it is not that complicated. We have been giving TLE. That means we are giving 3 drugs, which are tenofovir, levipimir, and effervescin. These are drugs we have been giving earlier, and we used to start in all the patients who come to us during the pregnancy. For the first time when they are diagnosed, or when they come to us in pregnant or breastfeeding with HIV already receiving ART, also we continue the same. We used to continue the same treatment. And also when she used to have other infections, or when she had received nevirapine in her first pregnancy, we were adding leponavir, ritonavir instead of effervescin. But there have been some changes in this last year recently. We are talking of another drug instead of effervescin, that is dolutegravir. Now, it has been seen that any person who comes to us in adult comes to us in more than 10 years of age with either HIV 1, 2, or both together should be given a combination of tenofovir, limodivine, and dotavir as one tablet dose, that is TLD, to be taken once daily with or without food at bedtime at any fixed time for the convenience of the patient. These guidelines have been given by WHO ART policy brief recently only in 2019. Now, why are we talking of this new drug? Because there are many advantages. It leads to rapid viral suppression as compared to fluvoxamine, with the average of normally the drug takes 3 months to be effective, but with this drug, it is effective in only 4 weeks. Then there are very fewer side effects. That is why there is minimal discontinuation, and there are less side effects like rash, neuropsychiatric events, etc. Only one study reported that insomnia was more with this drug DTG as compared to the other drug. There another advantages are it has a high barrier of developing drug resistance. It is more effective for PPCT, and though there are fewer interactions with other drugs like rifampicin, metformin, and antacid, etc., it can be taken in a twice a day dose during the day. And it is another advantage is that it is very effective for HIV-2 virus, and it is available in both forms as single drug or in a combination. So WHO 2000 guidelines say that it should be given to the women of childbearing potential with a greater maternal viral suppression, with fewer maternal deaths, fewer sexual transmissions, fewer mother-to-child transmission, and it is predicted to be more cost-effective and outweighs the risk of adult morbidity resulting from the drug, because it has a great, the only disadvantage it has is a weight gain. So if we take a good diet, we will not be having this problem. Now, a little about a woman of adolescent and adolescent of childbearing age. We need to counsel them about the increased risk of neural disease. It has been found that in first 4 weeks of conception, there is a slight, normal, the risk is 1% for any pregnant woman. With DTG, the risk becomes 2%. So whenever we have to give these drugs, we have to inform the patient, tell her the benefits of the drug, and give her the option to replace this drug. And then we can always give, because it gives rise to good viral load, we can tell her to continue this drug during her pregnancy. Now, there are different ART regimes in ART naive females in reproductive age. Who do we want to take the DTG? In a female who is at the risk of pregnancy, does not want to take, then we give or a single dose of nevirapine has been given. We have to give her TLD and lopinavir combination if she has been given nevirapine. But if she is willing and if she understands the benefits, then we can always give her TLD. Now, this is a small chart which shows that how do we give the drug, how do we shift the patient from one patient to the one drugs to the other regime. A patient is already on ZLN with non-dolutegravir based regime. We do her viral load test. If the viral load is less than 1,000 copies, then the regime can be changed to TLD. If the load is more than 1,000 copies, we continue the same regime for another 3 months with strict adherence, and then repeat the viral count. If the viral counts are suppressed, change to TLT. If not suppressed, evaluate the patient for failure. Why her counts are not going low. So to summarize this new drug which has come to stay with us is that WHO and NACO both recommend first-line treatment of ART naive patient living with HIV as TLD. Women of childbearing potential should be allowed to make an informed choice after explaining the benefits as well as slight risks related to the DTG DTG has numerous benefits such as faster, greater viral suppression, fewer mother-to-child transmission, and fewer side effects, and higher barrier to developing drug resistance. Hence, NACO recommends transition of patients to DTG-based ART regimes, and PLHIV on DTG need to be advised to take healthy diet and regular exercise to avoid the higher weight gain. These are the few side effects I had discussed. They are like insomnia, headache, dizziness, tiredness, some allergic reactions, and the little increase in the risk of neural defects. DTG is associated with weight gain, so we have to take a healthy diet and do exercise. These are the side effects of other drugs which we take, like DLE, like nausea, headache, diarrhea. We all know about it. They have to be treated symptomatically, and assurance, because with the time they will all go away and patient will settle down on them. And similarly, a patient may be suffering from CNS side effects or fatigue. Similarly, we have to give them symptomatic treatment, give them assurance and support, and they will also, with the time, be all right. Fever, rash. Only thing is, if a patient develops jaundice or abdominal pain, pain in the flanks, we have to stop the drug and examine the patient further and stop the ARV and take for advice from a specialist. So ultimately, it is very important for the patient to counsel her again and again. I am stressing this need of counseling for the adherence of drug, because this is the most important thing for all patients. She has to know, she has to have knowledge of precautions taken during the pregnancy, breastfeeding, avoid regular use of condom to avoid other STIs and a reinfection with different HIV strain. Adherence of ART during the pregnancy, labor, and breastfeeding cannot be emphasized more than I have already explained. Then antenatal counseling, the breastfeeding options should be counseled about to the patient during the antenatal period so that she knows how to go about it. Then we have to reinforce it postnatally also. Care of nipples starts from the first trimester in these women so that she does not suffer from any cracks or nipples. And then good nutrition counseling for herself is most important. And handling of the food for hygiene is again very, very important, along with the iron and calcium supplementation. Now, what are the modes of delivery? We have to tell the patient that institutional delivery is very, very important, and they should, and the normal vaginal delivery is recommended for all patients. Cesarean is only to be done for obstetric reason. Otherwise, there is no indication from WHO or NACO for cesarean in any patient. Coming to the labor, we all know that we have to do minimal vaginal examination. Partogram is very essential because prolonged labor can lead to risk of transmission. So we have to shorten the labor by giving oxytocin and avoid PROM. Then when we talk of labor, it is very essential to avoid any kind of trauma, any invasive procedure, avoid episiotomy. Though I am a great fan of episiotomy, but I still feel that if we try, we can avoid the episiotomy and give a good perineal support. And also instrumental delivery like faucet and vacuum have to be avoided, and cord clamping has to be done early. And when it comes to the baby, we have to clean the baby's head, clean the baby completely, and then give to the mother. Now, if a woman comes to us directly in the labor, the first thing is test her, screen her for HIV, of course, after taking consent. And then if she is positive, initiate her treatment, and then later confirm her test again, and then start ART as per the guidelines. Now, a little about abortion. We are talking of pregnancy, but we should also know of abortions. WHO recommends that safe abortion service should be given to the woman with HIV who wants to have who wants to have an abortion. It also suggests that women living with HIV uh, should be offered a choice of medical as well as surgical abortion. The abortion services should be free and offered with respect and non-judgmental manner, and healthcare workers should be offered with most respect to these women, providing access if she is desired, and ensuring to make the help them making the choice for the abortion. Now, to recap, we may have these two, three, four types of cases, as I already discussed. Women detected during the routine antinatal care, it is registered in the pre-ART care, woman who is already on ART, or women may come directly in labor. So all these patients, as I already start the ART after taking a consent and counseling immediately and adhere to the treatment throughout the pregnancy. So to follow up has to be there during the pregnancy, during the delivery, and during the post delivery. And she has to have a good antenatal visit, ART initiation, nutrition, safe delivery, breastfeeding. Spouse testing is very, very important. Family planning has to be counseled to both couple. Nutrition, even for the baby, is very, very important. Mixed feeding is to be avoided, and immunization and growth monitoring for the baby is very essential. Uh, Today only I was reading in the paper that this year we have the word in the dictionary by Oxford for the Hindi dictionary is Atmanirbharta. And do you know that in India we manufacture the most of the HIV drugs, and it is an amazing, amazing fact, and most people do not know about it. And today we cannot talk about this, but future is there when we will also speak like this. That I tell you, I don't even remember only that the time I think about HIV is when I have to take my medicine twice a day. These were said by Magic Johnson, and sooner we will also be talking about these things. I am sure very, very soon we'll be talking of these lines. Thank you very much. And with the motto that no child should be born with HIV, no child should die because of HIV, and no child should become an orphan because of HIV. Thank you very much for patiently listening.
Okay. Thank you, Dr. Anju Soni. It was really a great deliberation, and we know that on the words HIV Day, our minister said that we are already diagnosing and treating very well, and 2030 is far enough. They are doing India is doing very well. And this DTG new medicine, I think will be very well available in the market very soon. It's available. Okay. Okay, that's great.
It's already available in ART centers.
Yeah, and then this this
So,
non-judgmental.
Madam, it is already available at ART
Okay.
centers now.
Okay. Then I was thinking that it's in research hospitals only.
No.
Okay, it's freely
I have
available now.
added this because it is available at ART centers now.
No, not
The
ART
mother has to be
centers. No, that's what I was saying.
Yeah.
It is available at the centers only, and very soon it will be freely available.
No. It is available with the pharma also.
Okay.
It's available with the pharma also.
Okay.
Yeah, it's
Then
available.
we very nicely said that while doing vaginal deliveries and cesarean section, what precautions are to be taken, and 330 are to be remembered. That in India there should not be any infection, like 0 new infections, and 0 HIV related deaths, and 0 discrimination. That is the motto.
The most important thing, ma'am, you have said, discrimination is the biggest thing which we are having with these I will not call them patients, these mothers and the children and their husband. This is a very big thing which not only in our country but in all over the world, discrimination is the biggest problem which they are suffering, which we have seen.
But still the time is changing, na? Abhi the sab log accept
No, ma'am, I think we are still there, because I think all of us have seen lots and lots of discrimination, even in the case of this
ये
COVID
सभी में
virus.
है वो डिस्क्रिमिनेशन तो थोड़ा सा अपनी लाइफ में रहेगा ना, हेपेटाइटिस बी आ जाएगा तो अब क्या करना है, मैं इसको सेंटर पे ही भेजना है,
नहीं तो मैम
जॉन्डिस आ गया इसको क्या करना है, सेंटर पे ही भेजना है।
मैम एजुकेशन से हम नहीं बच पा रहे, हम डिस्क्रिमिनेशन पे से गिरे ही हुए हैं। तो डिस्क्रिमिनेशन इज वन थिंग विच वी हैव टू कीप अवे एंड वी हैव टू
डिस्क्रिमिनेशन ना होता तो फार्मर्स आंदोलन भी ना होता।
Thank you, Dr. Anju.
Okay.
She is ever active chairperson of the HIV committee.
So
And
thank
she
you
has
for your
Rajendra
kind
Prasad
words.
sir,
very nicely.
Thank you for your kind words. sir.
Namaskar.
Thank you.
Very nicely she has elaborated mechanism and timing of transmission, intrauterine, intrapartum, postpartum infection, basically the screening of HIV and intervention to reduce MTCT, termination of pregnancy, then all the antiretrovirals, role of elective LSS, and social and psychological impacts. It's really very nice. Thank
Yeah,
you.
this
Thank
DTG
you.
medicine is cost effective also.
Yes, madam.
Achha.
Very cost effective.
Okay.
Yeah. So we are now giving TLD, not TLE.
हाँ तो TLE से तो चेंज हो गया ना, TLD हो गया।
हाँ जी, हाँ जी।
चलो ठीक है।
So after that crash course on HIV, I don't know how she managed to cover the whole of pregnancy,
really
labor,
very
delivery,
good.
and post-delivery treatment in half an hour. But hats off to her. We
Yeah.
have our very eloquent Alok Sharma ji, and he's going to enlighten us on RH negative pregnancies. And for his formal introduction, I will request Dr. Rashi Mishra ma'am to please do the honors. Ma'am, please unmute.
Hello. Yes, I'm
Yes,
audible.
ma'am. Please go ahead. Yeah.
Dr. Alok Sharma is Assistant Professor, Dr. Rajendra Prasad Government Medical College, Kangra in Himachal Pradesh. Founder Secretary of Indian Menopause Society, Shimla Chapter. Founder Secretary of Indian Fertility Society, Himachal Pradesh Chapter. North Zone Coordinator of Hello Tomorrow CMEs. Advisor to Sexual Medicine Committee, FOXY. Member of Public Awareness Committee, FOXY. Member of Adolescent Health Committee, FOXY. Welcome, sir.
Thank you, Dr. Rashi, for this nice, kind words. So, and at the outset, I would like to thank Dr. Pratik Tambe. He is so generous and always remembers me whenever I have to deliver any talk or whenever any slot is available. So I am the first one in his mind. So I thank you, Dr. Pratik, for this. So I will be talking on improving fetal outcomes in RH negative pregnancy, and I was also amazed to see the how much is the prevalence, and regarding the epidemiology, I was startled that my state is on the top of having this RH negativity in my state. So next slide, please. So this is the global burden which the slide is showing. Like in 2010, we had got 373,300 babies which was affected worldwide, and global prevalence is 276 per 100,000 live births. And 80% of the babies of RH disease and extreme hyperbilirubinemia were born in countries with neonatal mortality rate of more than 15. And neonatal deaths due to RH disease is 24%, and it is a major chunk. Connectors showing 50%, and 7.2% of all RH diseases affected who survived developed connectors. And this, if we see this diagram, it's the stillbirth and neonatal death due to RH negative disease in South Asian countries such as India, Afghanistan is so high. So the burden is quite high, and that is why the topic has been taken and to discuss it in high risk pregnancy. Next, please. And now what I was talking is prevalence in our country, that is India, and state-wise. So the Himachal Pradesh, we are having 10.7% of RH negativity prevalence. And the least, if I just studied this, is Arunachal Pradesh is the least. And the only country, if you see, with this Rh negativity. So I think the more hilly region and the more I think Rh negativity could be the possibility. But again, some mismatches there. But this map is showing and the percentage with the maximum with Himachal Pradesh and Uttaranchal. Next, please. In the pathophysiology, everybody knows we have got two commonest systems for blood group classification. That is ABO system, rhesus. In ABO system, we have got A, B, AB, O antigens. In rhesus system, we have got C, capital small, capital D, small. We don't have small d, but yes, we have got E, E, and G. So there is no D antigen. The letter represents absence of D antigen. So the D antigen is considered to be the most immunogenic, also known as Rh factor. Next, please. To continue that how the Rh negativity is transmitted from mother from the couple to the children. In the first instance, if father is Rh positive and mother is Rh negative, with the one copy of RHD gene from father and no copies from RHD gene from mother, we have got half the children with Rh positive. But if we have got two copies of RHD gene in Rh positive father, then and no copies in RHD gene in mother with Rh negative. So she is negative with no copies. So we have got all the children which are all the children are Rh positive. But with one copy and negativity in Rh mother, we have got half children Rh positive and half children Rh negative. Next, please. In the feto-maternal hemorrhage and Rh incompatibility, how this Rh incompatibility is seen in feto-maternal hemorrhage, the amount of fetal blood necessary to produce Rh incompatibility varies, but as little as 0.1 ml of Rh positive cells have been documented. Studies have been suggested that up to 30% of persons which are non-responders with Rh negative blood never develop Rh incompatibility even when challenged with large volumes of Rh positive blood. So, Rh alloimmunization occurs by one of the two mechanisms, either with having incompatible blood transfusion or after feto-maternal hemorrhage between mother and an incompatible fetus. So, these are the two mechanisms, the major mechanisms where feto-maternal hemorrhage is seen and Rh incompatibility occurs. Second, next slide, please. Next, yeah. So the feto-maternal hemorrhage may occur during pregnancy. So again, the pregnancy is a part in which the feto-maternal hemorrhage occurs, and 10% it is seen during pregnancy, and 90% is seen during delivery. Now, notwithstanding, fetal RBCs have been detected in maternal blood in all the three. That is, all the three trimesters. 7% in the first, 16% in the second, and 29% in the third trimester. This is the apparent predisposing factors. The initial maternal response to rhesus sensitization is low levels of immunoglobulins, M antibodies. So these are confined to maternal circulation, being unable to cross the placental barrier. Next. Within 6 weeks to 6 months, IgG antibodies are formed. These are able to cross the placenta and destroy fetal Rh positive cells. Therefore, the firstborn infants with Rh positive blood type are not affected. So, the firstborn children with Rh and a negative mother are quite safe, but the short period of first exposure of mother to fetal RBCs is insufficient for production of significant IgG antibody response. Next. Now, what is the sequence of in utero events in a hemolytic disease of newborn? That how this hemolysis occurs. Now, first of all, maternal IgG enters fetal circulation via placenta. Destruction of fetal red cell occurs when the maternal IgG enters. Heme is, and this causes fetal anemia with the hematocrit of less than 30%. Heme is formed and converted to bilirubin, that is, fetal hyperbilirubinemia occurs. Both are neurotoxic, but effectively cleared by placenta and metabolized by the mother. After this, extramedullary erythropoiesis is stimulated, and this causes immature erythroblasts are produced. Next. When cell destruction exceeds the production, severe anemia occurs, more demand on extramedullary sites to produce more red cells, causing hepatosplenomegaly, leading to heart failure, eventually results with ascites, edema, and pericardial effusion, and thus creating the picture of erythroblastosis fetalis. And finally, it is hydrops fetalis, occurs when the hematocrit falls below 15%, often results in fetal death shortly before or after birth. And minded male to female fetus for hydrops fetalis, we've got 13.1 to 1. That is, males are the most affected with hydrops fetalis. Next. So this is the pictorial diagram how it is affected. Male is positive and a female is Rh negative, and a couple where father is positive conceive with Rh positive baby. When a male with Rh positive blood and the female with Rh negative conceived with Rh positive baby, so Rh isoimmunization is not a problem at the time of first pregnancy, at the time of delivery, and rarely in antenatal period. But the Rh positive antigens move into the maternal blood through the placenta circulation, and these Rh positive antigens stimulate the formation of anti-Rh negative antibodies in the maternal circulation. Now, in the subsequent pregnancies with Rh positive baby in the womb, these anti-Rh antibodies the Rh positive RBCs, resulting in the development of fetal complications like anemia to start with, and then destruction of fetal red cells, including anemia, heart failure, and death buildup of bilirubin resulting from red cell destruction leads to jaundice and brain damage. Next. Rh sensitization. Now, the risk and severity of sensitization response increases with each subsequent pregnancy involving an ABO and compatible fetus with Rh positive blood. Without prophylaxis, this risk is 16% after 2 deliveries. 1.5 to 2% occur antepartum and 7% within 6 months of delivery. 7% manifests early in second pregnancy. So with prophylaxis, the risk drops to 0.1%. So this is why this prophylaxis, the anti-D prophylaxis is important in pregnancy and further subsequent pregnancies to drop the risk of Rh sensitization. Next, please. The aforementioned risk depends upon the three factors: the volume of transplacental hemorrhage, extent of maternal immune response, and the concurrent presence of ABO incompatibility, that is, the protective risk drops to 1.5 to 2%. So Rh incompatibility is only of medical concern for females who are pregnant or plan to get pregnant in future. So you always ask the patient, like if it is gravid, if it is para 2, whether she is going to have conceived the next pregnancy. So it is good to have an anti-D prophylaxis to the mothers during pregnancy and with the subsequent pregnancies if she wants to conceive. Next, please. Now, in the management, we first go and see for the history for potential sensitizing events. So, what are the sensitizing events where the feto-maternal hemorrhage is occurring? So, when feto-maternal hemorrhage can occur, so in that we are going to see the history of any abortions or any suction and evacuation done to the patient, any invasive procedures, that is amniocentesis, choriovenous sampling, and any abdominopelvic trauma, APH, including placenta previa abruptio, in IUD, intrauterine fetal demise, multiple gestations, MRP, very important. MRP causing much more like if it is Rh negative and you are doing MRP, then you are creating more and more of feto-maternal hemorrhage and causing sensitizing event. Ectopic pregnancy and cesarean delivery. Next. Other aspects of the history to be explored include prior blood transfusion, Rh blood type of patient and spouse, all previous pregnancies, outcomes and interventions, history of hydrops. If it is there, there is a 90% chance that it would recur. So more surveillance is required if there is a history of previous hydrops. previous administration of Rh-IgG, mechanism of injury in case of maternal trauma during pregnancy, presence of vaginal bleeding, and prior any invasive procedure. Next, please. The objective of management is again very clear that we have to prevent the Rh immunization in the Rh negative unsensitized women, early detection and treatment of fetal anemia in the sensitized women. Sensitization is determined via the indirect Coombs test, otherwise called antibody screen. So ICT, again, it is a very important test and it has to be done during antenatal period. Looking for precautions during delivery, ensure consultation. Neonatologist should always be there. Don't give much oxytocics at delivery of anterior shoulder. If MRP is required, do so, but gently, like manual removal of placenta if it is done. BT is indicated, use a Rh negative blood only. Early clamping of umbilical cord is indicated. Leave a long cord about 15 to 20 centimeters so that if there is exchange transfusion is required, so cord could be utilized. Next. In postpartum management, again, a neonatologist has to be taken into the consideration. Cord sampling, including ABO-RH, DCT, HB, bilirubin levels, and peripheral smear for the baby. If fetus is Rh negative, no further intervention is required. But if the fetus is Rh positive, determine the dose of Rh-IgG to be administered by 4-step lab procedure. Now, what is 4-step? Next. In the fourth step lab procedure, we have to go for 4 investigations. Like we have to see for rosette fetal RBC screen for fetal-maternal hemorrhage if positive. Acid dilution, that is Lee-Hard-Butke test to quantify the RBCs in maternal circulation. Estimate the volume of fetal-maternal hemorrhage, that is 50 into percentage of fetal RBCs, and calculate the dose of Rh in IgGs to be given within 72 hours of deliveries. So these 4 things we have to done. We have to do, like rosette fetal RBCs have to be seen for fetal maternal hemorrhage. If it is there, then quantify the RBCs in maternal circulation. If again quantify, then how to quantify? Estimate the volume of fetal maternal hemorrhage, that is 50 into percentage of fetal RBCs, and administer the dose of Rh-IgG, that is anti-D, after 72 within the 72 hours of delivery. Next, please. This is how it is that positive rosette looks like. Next. Acid dilution test. Again, these are pathological procedures and the slides which are taken from the Department of Pathology. Next. For sensitized women, management is guided by the following. Presence or absence of history or affected fetus in previous pregnancy with severe anemia or hydrops, which we have to go into the history. Maternal antibody titers where no prior history has seen. Sensitization may be determined by doing an antibody screen using ICT. Next. This is how DCT is done. Now, I'm not going into the details of how DCT and how these samples are taken. It is very nicely, and everybody knows it, that when DCT is to be done and when ICT has to be done. So DCT is performed like on baby's blood, and ICT on antenatal mothers to check for any sensitizing event and sensitization. Next, please. Next, please. This is ICT. Now, anti-D prophylaxis guidelines. Now, very important and the practical amongst the whole this talk is anti-D is an antibody against D epitope present on fetal RBCs to prevent the Rh negative women from sensitization. And how it occurs, like anti-D immunoglobulin passive injection coats the D epitope and prevent the interaction of maternal immune system with Rh positivity. 300 micrograms anti-D neutralizes 30 ml of fetal Rh positive blood, that is 15 ml packed fetal RBCs. Available anti-D preparations, we've got 2 preparations, monoclonal and polyclonal. Next. In monoclonal anti-D immunoglobulins, it is the highly specific antibodies against single antigen epitope produced by the clone of a single hybrid cell formed in the lab by the fusion. And what are the advantages of monoclonal anti-D immunoglobulin? It is specific, consistent, uniform, and safe from transmission of viruses and harmful proteins. Next. Polyclonal anti-D immunoglobulins derived from sera of immunized humans made up of mixtures of antibodies with affinity for a wide range of antigenic epitopes. It is difficult to manufacture in large quantities, difficult to provide consistent batches, and chances of transmission of infection with harmful proteins it always there. Next, please. So the guidelines recommendations for anti-D prophylaxis, uh, all ACOG, RCOG, FOGZ, BC, SH, NHS, SOGC, and RANZOG, they have got postpartum prophylaxis of 300 micrograms within 72 hours of delivery. So even our FOGZ recommends 300 micrograms of NTD prophylaxis within 72 hours of delivery. That it should be taken home message that whenever any of the Rh negative female is delivering a baby with which is Rh positive, 300 micrograms of NTD prophylaxis has to be given, asking her that whether she is going to conceive in or she is going to have the next child within 72 hours of delivery. And during sensitizing events, as I described the sensitizing events earlier, that if there is any event occurring during antenatal period, so what are the less than 12 weeks, so we have got 50 to 120 micrograms, or more than 12 weeks we have got 300 micrograms. Fogsy says it is 50 to 100 micrograms, whatever is the period of gestation. So but I also think, and most of the societies, they are telling that it is 50 or 50 micrograms of NTD should be administered if the event is less than 12 weeks. But if it is more than 12 weeks, we can go for 300 micrograms. Next, please. So this is the management of sensitized Rh negative women. If there is no previous history, again, it is all the summary which we have discussed earlier. Though this flow chart shows the summary. So the no previous history of affected fetus, obtain the ABO and Rh group of husband if there is no history of affected fetus. If positive, obtain antibody titers. If negative, no further testing is required. So if it is positive titer, then if antibody titer below critical level by 36 weeks, continue pregnancy to term, but not allowed to be post-dated. If antibody titer beyond critical level after 34 weeks, deliver immediately after 34 weeks. But if antibody titer is beyond critical level before 34 weeks, then further testing has to be done. That is, we are going for Dopplers. Peak systolic velocity of middle cerebral arteries are taken. Then amniocentesis for analysis and spectrophotometry, and ultrasound examinations of the fetus. Percutaneous umbilical cord blood sampling for hematocrit and Rh negative. But if it is previous history of affected fetus, then establish sensitization. Chordosynthesis is for determining fetal hematocrit Rh genotype if father is heterozygous. Amniocentesis for amniotic fluid spectrophotometry and assays. Initiate MCA Doppler surveillance from 18 weeks if there is previous history of affected fetus. Next. Fetal assessment of hemolysis, then how it has been done. Amniocentesis and checking ODD for 450 to check level of bilirubin in AF, and it is optical density. Then fetal blood sampling and checking for fetal hemoglobin level. Next. Again, these amniocentesis, chordosynthesis, if it is seen that you find that it is the sensitizing event, then specific centers you have to choose which are performing you see if these centers are recognized around your center. Like in Himachal Pradesh, it is very difficult to find these centers going for chordosynthesis or going for amniocentesis. We have to send, or we have to refer the patient to the more metro cities like Chandigarh or Delhi. But yes, for Doppler velocimetry, we can take care of, and Doppler is what we are doing in our medical colleges or in the peripheries of Himachal Pradesh. And how it is middle cerebral artery Doppler velocimetry. It is accurate and non-invasive screening tool for detecting moderate to severe fetal anemia. A sensitivity of 100% and a 12% false positive rate for anemia. It is used as resulted in 80%. That is reduction in invasive testing. Amniocentesis and chordosynthesis has been reduced to 80%. Next. So in this, I can see middle cerebral artery Doppler is again better option if you are going to surveillance or maternal and fetal surveillance if we are going on. But not useful before 18 weeks of gestation because reticular endothelial system is too immature to hemolyze enough cells to cause significant anemia. It is not a reliable predictor of severe anemia after 30 weeks. So if it is like that and you are the pregnancy has been continued post 34 weeks, you can go for delivery also if some serious issue is there. Found to be similar or better than amniotic fluid optical density 450 in prediction of anemia. Next. This is the normal versus abnormal middle cerebral artery peak systolic volume. The normal picture you see, and this is how the RH isoimmunization picture has been seen. Next. The results of middle cerebral artery Doppler velocimetry in unaffected or mildly affected fetus. Normal MCAD is like a middle cerebral artery Doppler. It is after lung maturity, low risk of intrauterine fetal death. In moderately affected, we have got about 1.5 multiples of median. Repeat 1 to 2 weekly. Deliver after lung maturity. Enhancement of lung maturity may be necessary. In severely affected, if MCAD is more than 1.5 multiples of median or has frank evidence of fetal eye drops, fetus needs help to attain lung maturity before delivery, but high risk of intrauterine fetal death is there. Next, please. So these are the two spectrophotometric charts, Lilly and Quinans. When you and according to Lilly, which is not accurate before 26 weeks, but Quinans can be used from 14th to 40 weeks of gestational age. But these are again a spectrophotometry, and when you are going with analysis of amniocentesis also. So these are seen when the centers are fully covered with all amniocentesis, chordocentesis, and so this is how these two charts work. Second, next please. In RH sensitized pregnancy, like if MCA Doppler velocimetry peak systolic velocity, if it is 1.5 moms and above, then fetal blood sampling and consider termination. But if no facilities for fetal blood sampling, amniocentesis, then again we MCA, if it is these are if it is above, then you have to go for amniocentesis. But if it is less than, then monitor MCA PSV 1 to 2 weekly. Next. So intrauterine blood transfusion is required recommended treatment for severe hemolytic anemia in utero. Typically, it is carried out between 18 to 35 weeks gestational age. May be given intraperitoneal or intravascular also. ORHD negative flagged cell, which is used when you are not getting the blood with hematocrit of 80% can be used. Amount to be transferred in ml is gestational age minus 20 into 10, where gestation age is more than 20 weeks. So this is the guidelines when you are doing blood transfusion for severe hemolytic anemia in utero. And these all are performed in very like highly if you say कि एक बहुत ही अच्छे और खुली लैस जिन पे fetal medicine जिस पे perform होती है, तो these centers are nominated and very clear cut centers. Like in every center you cannot perform intrauterine blood transfusion, so you have to label those centers and can transfer your patient or can refer to the patients with whole of your consented and counseled. Next. This is the pictorial diagram of intravascular intrauterine blood transfusion. Next. So, and the sensitized Rh negative women in the postpartum management of the neonate, baby, if alive, should be admitted into neonatal intensive care unit. An urgent exchange blood transfusion is indicated to moderate to severely affected neonates, and phototherapy for mild affection only. So, if for mild infection, we are not going to do anything until or unless your neonate is affected severely, then only you are going to exchange the go for exchange blood transfusion. Next. Special fetal maternal risk states are like abortion, up to 5% chance of sensitization, and 50 micrograms is recommended. Invasive fetal procedure, up to 11% of sensitization, a dose of 300 micrograms is recommended. This is the doses that how much NTD is required in specified cases like abortion, 50 micrograms, less than 12%, less than 12 weeks of gestation. But if it is invasive fetal procedure, then go for 300 micrograms. If it is APH, then 300 micrograms. Start to be repeated 12 weeks later if pregnancy lasts that long. If ECV is done, external cephalic version is done, and there is a chance of 6% of sensitization. So the dose is 300 micrograms of NTD is to be required. Next slide, please. Delivery with fetal-maternal hemorrhage. The normal amount of fetal blood that enters the blood circulation is 0.5 ml only. So the dose of RH IgG given is 300 micrograms will neutralize nearly 30 ml whole fetal blood. I have told it earlier. Management is guided by estimated volume of fetal-maternal hemorrhage determined by the fourth step lab test, that is Rosettes and all. Then dose of RH IgG given after sensitization is at least 20 micrograms per ml of fetal RBCs. Next. Non-invasive fetal RHD genotyping from fetal cell-free DNA in maternal circulation. Point of care tests, POCT, that is rapid test for determining RH status. A lower 50 micrograms dose preparation of RH IgG for the use of following first trimester abortions. Concept of partial D and weak D antigens usually test positive, but can also form anti-RH antibodies. So these are the recent advances that non-invasive fetal RHD genotyping from fetal cell-free DNA in fetal circulation, POCT. So a lower dose of 50 microgram has been also developed. Next. The take-home points is every woman of childbearing age should have her ABO and RH types done at first contact. Obtain the ABO RH types for husbands of women found to be RH negative, and a single postpartum dose may be inadequate in cases of severe fetal-maternal hemorrhage. We can repeat the dose after 12 weeks, but pregnancy should be carried out. Next. But problems in our setting is that we have got very high cost of immunoglobulins, lack of resource, and our patients do belong from the lower strata. Most of the patients being in India and a developing country. So this high cost may sometimes the patients may drop. So the lack of resources to adequately investigate and monitor fetus in utero, low turnout for antenatal clinics, we miss the cases. As soon as you say that this much is the amount of anti-D, the patient either don't come or they miss your clinic. Poor documentation of prior sensitizing events. Some are yet to fully grasp the import. So once the event has been occurred, your discharge card or your event should mention all the documentation regarding your event, so that the next pregnancy or the next clinician should know the event, that how the previous fetal-maternal hemorrhage could have been sensitized this mother. Loss of case notes, as I mentioned. So that the case should be properly reported and mentioned on your summary. Next. Recommendations is advocacy for partnership by government and NGOs to help subsidize the cost of immunoglobulin. In that case, our state, we are giving the immunoglobulins, the anti-D injections free of cost under the Government of India scheme. Special insurance cover for RH negative women to ensure ease of procurement when needed. Involvement of clergy as a part of premarital counselors. Creation of special forums, groups for RH negative people where potential RH negative spouses can be met. Next. To conclude, RH alloimmunization is a real problem and real efforts need to be made to mitigate its impact. Although its incidence has decreased dramatically, yet the consequences of hemolytic disease of newborn remain, and the great advancements have been made in the detection and management of this condition, and many of RH negative women can now have a happy obstetric career. Next. Thank you.
Thank you so much, Dr. Alok. He has explained very nicely prevention of alloimmunization, and it's a quite extensive lecture, but he has taken very nicely process of FMH, role of womb test, antenatal and postnatal management, then management of sensitized Rh negative mothers, and importantly, he has explained nicely the role of middle cerebral artery velocimetry Doppler in this, and all the recent techniques, meaning intrauterine transfusion and all that, even recent advances in fetal RSG genotyping. It's a really nice talk. Alok, congratulations, Alok.
Sir. Thank you, sir.
Archana, hello.
I think Dr. Archana Verma might be with a patient. I can see her
I'll-
logged in, but her audio video is off. In the meantime, I would request Dr. Rashi Mishra, who is one of our other chairpersons. What is the incidence of RH isoimmunization and HIV? Today's two topics where you practice, ma'am. Is it widely prevalent? And Dr. Anju Soni was talking about discrimination. Is it still widely prevalent even in good large cities like Kanpur? What is your view on the whole situation?
Sir, RH aluminization is common in rural settings because in UP government hospitals are very far way behind. I am basically from MP, and I have seen MP PHCs also, like postgraduate. I have done my postgraduate bond practice in PHC CHC level also, but here like there is a drastic difference in government setup in the UP and MP. RH aluminization is there seen. It has been never seen during my practice in MP, but it has been seen in UP practice. HIV positive cases, sir, I have seen mostly during my PG in private practice. It's like not very much seen HIV. It's
Dr.
during my
Rashi, have you
PG
ever
only.
has any patient come to you with HIV positive who wants to have an IVF pregnancy?
During my PG, during my PG, I have taken post-exposure prophylaxis. I have got needle prick with HIV positive. We were delivering her vaginally, and I got needle stick with that patient. And I've taken post-exposure for 1 month and developed jaundice and myopathies and everything. It was it was my very one of the very terrible experience.
Too close for comfort.
No, I was asking you a different thing. I was asking you, have you ever done IVF for an HIV positive woman?
Hello.
Yes, ma'am. The question was whether any HIV or barrier nursing positive patient has come forward for ART, that is IVF treatment.
ART. No, sir, not yet.
So I think it's much less prevalent in the smaller towns.
Yeah.
Most of those
Yeah.
patients probably would not seek treatment in the same city where they stay. They would
Yes.
usually come to
They
large
always prefer to
metros.
go to
Seen
yes. They
hepatitis
go to the other metros.
HIV positive.
Yeah.
Thank you, Dr. Alok and
Yeah.
Dr.
Normally
Anju
they go to
Soni. Two fantastic talks. We have a lot of compliments for you from the audience. I'll just read out a couple of the messages. Dr. Shirisha from Karimnagar says good. There are 2-3 other messages saying both the talks were excellent. And there are a couple of questions. We have time. We finished early today. So I'll just entertain these questions. The first one of these is for Dr. Anju Soni ma'am. And the question is, I don't have the person's name who has sent the question. The question is, when should antiretroviral therapy be given? Is there a particular time limit beyond which you cannot give it, or it does not give protection, or what are the guidelines? I think you've answered this, but just to repeat it for the sake of the audience, somebody might have tuned in late.
It should be started as and when the patient comes to you, as soon as possible, without looking for WHO staging, without looking for viral load. It should be started as soon as possible. But probably the person who has been wanting to ask the question he's asking for post-exposure prophylaxis. This is my guess, because his question is kind of turning to that side, that after how long it is effective. So when you have any prick, like Dr. Rashi just mentioned, this is again very, very important. And most of us, when we are working, sometimes you may get pricked not by yourself, you may get pricked by your nursing assistant's fault or anything. So it is very, very important to take prophylaxis at that time. The first most important step which we should take is that we should, we normally have a habit whenever we get any hurt, we put our finger in our mouth. That should never be done, number one. Number two, you should wash it with simple plain water. No antiseptic to be applied, and keep washing it in the running water. Number three, you should have TLD or TLE in your labor room, in your OT. So take it as soon as possible. Do not delay, because it is said the sooner you take, the more effective it is.
Better.
And it should not be taken. It is not effective after 24 hours or may 74 2 hours. So the dictum is this should be lying in your emergency tray, in your operating area, in your ICU, in your labor room. So I think he was wanting to ask this. I mean, that is why I've answered this question. Though we have not covered this topic, we'll cover it sometime later, whenever Pratik wants it. But this is also very, very important topic, not only for HIV, for other infections, because per se, most dangerous infection by pricking is not HIV, it is hepatitis. And the chances of getting hepatitis are much higher as compared to HIV. So we have to know how to take precautions, and what kind of, how to be away from this post-exposure prophylaxis. So maybe some other time we'll take it in details, but it is also again a very, very important topic for all of us, because we are all working in these areas.
Thank you, ma'am. That was a lovely and extensive answer, and you covered one more additional topic. So thank you for that. The next question is for Dr. Alok Sharma, sir, and this is Dr. Neelam Garg from Jaipur. She is asking, what about antenatal prophylactic administration of anti-D at 34 weeks?
It is, it was like we also do whenever it is seen that RH negative women is coming with the RH positive spouse. So we do, it is not 34, but at 28 weeks, it is do recommended that at 28 weeks, you are giving that prophylaxis. So it is, I think it is not 34, it is 28 weeks.
Absolutely.
You can give
this
thing.
There are two more comments. This is Dr. Shail Shastri from Ahmedpur and Savai Madhopur, Jaipur, saying nicely explained by both the doctors. So Dr. Anju Soni has a lot of fans and they've all tuned in today. This is the advantage of having national faculty. Though we have an AMOGS platform, if we had only people from Maharashtra, it would be a very small limited audience that logs in. But because we have such eminent national faculty, Dr. Archana Verma is here, Dr. Anju Soni, Dr. Alok Sharma, Dr. Rashmi.
It is nothing like, it is your, aapki soch hai ye.
It's your
this
brain.
Is how you think.
It's your brainchild, Pratik.
It is your
it's
thought.
Your brainchild, and
that is how you are catering.
The way you carry it along, I think it's amazing.
Thank you.
This is how
amazing
you carry
the way you carry it along.
Pratik is very active in AMOGS. He is a chairperson in the flying AMOGS, but ever active.
No, he is active in that kind also. How to cater all India.
Dr. Archana Verma has joined us once again. Thank you, ma'am, for making time out and taking time from your patients. I just wanted to ask you, in your practice regarding HIV, Dr. Anju Soni was mentioning that there's a lot of discrimination amongst doctors also, and of course, lay people is a different matter altogether. Have you also encountered this even today? Is it still widely prevalent in large cities like Delhi, Ghaziabad, Noida?
Actually, Dr. Pratik, this any infection, because I am a private practitioner, so what we think, we always refer the patient to a specialist care. And as such discrimination need for just proper and the management, and then there is no discrimination because all the there is a every corporate hospital is doing cases with hepatitis and HIV. There's no discrimination. वो sometimes it makes a difference कि हाँ payment का issue होता है तो then we send the patient to GTB and all. So again there is no discrimination. Patient has never come back to us कि we were facing this problem or that. And because maybe it is a small city, Ghaziabad, and we are highly connected with the patient. We give them ambulance and sometimes, and our staff also, they are very good. And the patient has a direct, he knows our address, they know our number, so they are very well connected, and they keep on telling everything.
I think things have changed a lot for the better. Both for us as clinicians, we are better informed, we are more aware. There is a
Yes.
less of a fear factor in our
Fear
minds
factor नहीं
also.
है.
And thanks to the internet and widespread availability of information easily, I think amongst lay
और ये तो
persons
पहले सर
also.
पहले दिन से ही पता है ना कि HIV
हाँ,
हाथ लगाने से नहीं फैल रहा है तो
exactly.
लाइक वी कितनी बार ऐसा होता है ना कि हम अपनी ही गाड़ी में बिठा के पेशेंट को दूसरी जगह जैसे कई बार अल्ट्रासाउंड के लिए भी छोड़ के आते हैं या कहीं
अभी
पर
वैसे
भी जाना
स्टिग्मा नहीं है पहले की तरह.
है.
Sharma ji, I wanted to ask you something. You started your talk by saying that one of the highest incidences of RH negative is actually in your state, and that's one of the important reasons why I selected you for that talk. So have you seen RH isoimmunization much more in your practice as compared to, say, maybe other small towns and cities? You're muted, sir. Can you unmute yourself, please?
It is very less I have seen ICU immunization. Maybe the state is doing good job, or maybe the we in the hospitals or we the doctors from Himachal Pradesh we are doing good job, but we are coming very less incidents of these kind of sensitizing things like high drops. I think I have seen in my years of practice only two cases. So it is like I have seen two cases. So maybe everybody has seen one to two cases. So, keeping in view, like 10%, like 10 was the figure given to Himachal Pradesh. So, in that case, Himachal Pradesh is doing good job by giving healthy children to the RH negative mothers. So, this is how I
Easy,
think
easy
very.
availability of anti-D also makes a huge
Yes,
difference, I
yes.
think.
This is also one thing that government of Himachal Pradesh has included anti-D in the free Matra Suraksha Yojana. So that is also a very good thing that we are and our staff. It is not only doctors but staff nurses. They are equally trained in that case. Like when the RH negativity is seen, they are going for DCT and investigations and giving anti-D and then informing the doctors on duty. Yes, doctor, we have given anti-D to that patient. Kindly mention it. So this gives a very good sense of responsibility also that not only doctors of my state but the
This
staff
is too
nurses
good.
of my state
If it is
are
they
doing
are
good.
giving it for the free if they are giving then postpartum immunization or antenatal also RADTP.
Madam, antenatal we have to prescribe, then it is free.
Asha, that is wonderful.
Yeah, that is free. But once we prescribe in our government hospital, then it is free.
I
We
think a
have to
lot of
prescribe.
यूपी में
progress
नहीं
has
होगा.
been made over the past 2-3
Yeah.
decades, and gradually we are seeing
यूपी में
less
नहीं
and
होगा.
less. And probably with the
And
advent of good fetal
patients are also
medicine services. Yes, ma'am. Please go ahead.
patient is also very intelligent nowadays
Yes.
about knowing their groups and all. Earlier people never knew their groups. Now people know what group they have, because of probably media or
Google
movies.
or internet ke side effects.
Ma'am,
Haan,
social
and
media is,
movies also.
and again, the rest thanks goes to ma'am COVID that has made everything virtual. So most of the people are on telephones, on smartphones, and all thanks to COVID.
One of the side effects of the
One of the
pandemic.
side effects of.
So before we close today's event, I would just request all the esteemed dignitaries to give us one simple take-home message for the audience, and then I'll present the formal vote of thanks. Pardeshi sir, any comments or final remarks for the audience?
So, see, RH negative mother. So it's very important, and you have highlighted. Alok has given nice talk. So we shouldn't be neglected, and if we neglect them, so that may be the recurrent pregnancy losses then, and it will be a heavy burden on us.
Thank you, sir. Dr. Archana Verma, ma'am?
RH negative तो मेरा favorite topic है. So public awareness for this primary
I think she lost the
immunization
internet
and
connection.
sensitization is a must. And if a gynecologist is taking history very nicely, then they know the sensitization has occurred or not,
Or
even
not.
if you are not doing the investigation and referring at the right time. We should no child should ever die of this jaundice and hemolytic anemia.
Thank you, ma'am. Thank you so much. Dr. Rashi Mishra, is she there? I see her logged in. Maybe she's with a patient. If she can't come forward, then maybe we'll have final remarks from Dr. Anju Soni and Dr. Alok Sharma, our two speakers.
I would like to tell every obstetrician, please, whenever a patient comes to you, do their HIV testing at the first visit. Do not leave this visit it should be utilized. The visit should be utilized. And when a patient comes, of course, after taking proper consent, and when a patient comes reactive, not positive, then we should not bombard them, counsel her properly that it could, we need to confirm it, and once we confirm it, then only she will be. So do not, I mean, we should deal with it very humanly. I mean, very, very humanly with the patient, and do not leave this opportunity. Connect them to the center. We are very, very near to getting MTCT certification, EMCT certification from WHO, and that certification we had the aim to get it 2020, but because of Corona, we couldn't get it. I need every gynecologist support that you test the patients and then you connect them to the centers so that we are able to tackle them. No child should be born. And it's my request. Everybody's effort will only take us towards this certification. 17 countries have already received this certification, including Sri Lanka. I think next country should be India. And that is my hope and that is my wish.
So with your efforts through Foxy, EMOGS, and all other professional organizations, we wish you all the very best in your effort, and very soon we hope to see you successful on that front as well. Alok ji?
हाँ मेरी तरफ से I feel that no RH negative female should deliver any crippled child, and every obstetrician should be aware of this anti-D prophylaxis correctly, and no crippled child should be delivered by RH negative mother.
Thank
So
you.
awareness regarding anti-D.
Thank you very much. So we had some wonderful discussions and we had some wonderful feedback also from the audience. I think today's program has been highly appreciated. To come to the last item on the agenda, I would like to present the formal vote of thanks as the convener for today's event. My gratitude to the AMOG's office
एक
bearers.
और
जी मैम.
पर ये कह रही थी कल एनसीडी प्रोग्राम जरूर ज्वाइन करिएगा सब लोग
हाँ
पब्लिक
जी
फोरम.
मैम. जी मैम. We'll be there. No worries. I'd like to express my gratitude to our President, Dr. Nanita Palshetkar, Secretary, Dr. Arun Nayak, Chairperson and Secretary of ICOG, Dr. Mandakini Meg and Dr. Parag Binimale, respectively. The chairpersons who are there today and graced the occasion, Dr. Rajendra Singh Pardeshi, our Vice President of AMOG, Dr. Rashi Sharma, the Vice President-elect of Foxy, Dr. Rashi Mishra, an eminent IVF consultant from Kanpur, and our two standout speakers, Dr. Anju Soni, Chairperson for the HIV/AIDS Committee of Foxy, and Dr. Alok Sharma, the standard bearer in Himachal Pradesh and Shimla for obstetrics. Thank you so much for being here. Our gratitude to our academic partners, Bharat Serums and Vaccines, the Feminora division, who have been helping us organize this entire Bridging Bharat series of programs, and Science Integra, Subbu, Session, Shrimon, Meenal, all of you do fantastic work. Thank you for being our backbone. Thank you, audience, for logging in, and we hope to see you very soon in the next event. Goodbye. God bless. Take care.
Thank you. Thank you.
Thank you,
Bye.
Thank
Pratik.
you so much. Thank
Thank
you.
you, Rajendra
Thank
sir.
you.
Thank you.